Hello everyone. My name is Yohei Yabuuchi from the Department of Gastroenterology, Kobe City Medical Center General Hospital in Japan.
I'm Kosuke Tanaka, also from the same department.
Thank you for giving us the opportunity to participate in this interview for gastrointestinal endoscopy. We are pleased to introduce our paper titled Safety and Efficacy of Underwater Endoscopic Mucosal Resection for 10 to 20 mm colorectal serrated lesions. See clear study. Now, Dr. Tanaka, let me ask you a few questions. Why did you conduct this study?
Colorectal-related lesions are precursors to colorectal cancers, and their endoscopic resection is crucial in preventing cancer development. However, traditional endoscopic techniques for resecting them larger than 10 mm often have unsatisfactory success rate. It is important to explore more effective and safer techniques. Underwater EMR is an easy, safe, and effective resection method for colorectal tumors, but its reports of effectiveness for serrated lesions was limited. Therefore, we conducted a prospective observational study to evaluate the efficacy and safety of underwater EMR for large serrated lesions.
What was the result of your study?
Okay, before explaining the results, let me briefly outline the endoscopic procedure and follow-up. We dissected the lesions by underwater EMR with spraying an acetic acid solution over the lesion to identify the margin and perform tattooing at the resection site. Surveillance colonoscopy was performed 12 months postoperatively to evaluate local recurrence. The primary outcome was the complete resection rate of underwater EMR, which was defined as en bloc resection with no neoplastic tissues in the 4 marginal biopsies and histologically negative margins. Next, I will explain the results. Underwater EMR was performed for 65 serrated lesions in 58 patients. We found that underwater EMR successfully resected all the lesions, with an en bloc resection rate of 87.7%, R0 resection rate of 61.4%, and a complete resection rate of 60%. Adverse events include 1 immediate bleeding and 1 delayed perforation requiring surgery. In follow-up, surveillance colonoscopy was performed in 50 patients with 57 scars. The recurrence rate was 5.3%, and all 3 recurrent lesions were completely resected endoscopically.
How would you interpret the results?
In previous studies of conventional EMR for serrated lesions sized more than 10 mm, the rate of en bloc resection, R0 resection, complete resection, and recurrence were as described, whereas these were as described in the present study. Although the statistical superiority of underwater EMR was not shown compared with conventional EMR, we have shown that underwater EMR is comparable to conventional EMR. Given the convenience of underwater EMR in eliminating the need for submucosal resection, underwater EMR may be an optical treatment.
What is your future perspective?
This study demonstrated that underwater EMR for large serrated lesions was comparable to previous conventional EMR outcomes. However, we were not able to prove which strategy of endoscopic resection is appropriate because this was an observational study of underwater EMR and not a comparable study. Looking ahead, we believe that a multicenter prospective comparative study between conventional EMR, piecemeal CSP, and underwater EMR should be done to establish the optimal strategy for the endoscopic resection of large serrated lesions.